So dear postgraduates, this class will be on the gouty arthritis. Okay. So far we discussed the introduction to the rheumatology, rheumatoid arthritis. Now this is the time to learn something about the gouty arthritis. It's again a chronic arthritis, one of the important arthritis in the men. It's a disorder of the urate metabolism. So something concerned with your purines, your proteins, your liver, your kidney, uricogenic effects, etc. involved in this metabolism. Finally results in the deposition of the monosodium urate crystals, not only in the joints but also in the soft tissues. So maybe in the ears, pinna, cartilaginous tissues, soft tissues, osseous tissues, etc. With accompanying inflammation. This is a chronic inflammation and degenerative consequences. It's a very common in the men aged more than the 40 years who are obese, who are metabolic syndrome positivity, and who are alcoholics and consume high non-vegetarian diets, high purine diets. So this is a typical picture. With history alone, we can diagnose the gouty arthritis here. The great toe. It's a very old disease. BC, podagra first identified by the Egyptians. So this is called as the podagra. The inflammation of the great toe is the podagra. Way back in the 5th century BC, Hippocrates, the father of our medicine, he referred the gout as unwalkable disease. So he can't walk with great pain. Almost the pain is as equivalent as the greatest of the great. The pain is gouty pain. Unwalkable disease, and noted the links between the gout and the lifestyle. See, way back in the 5th century, Hippocrates, a great fellow, he postulated that there were some links between this gout and the lifestyle diseases. That's true today. So the gout is very common in the obese individuals, it is very common in the metabolic syndrome people, etc. and demographics and other variables. The word gout is derived from the Latin word gutta. Gutta means a drop. It was believed that an acute attack of the disease was the result of a poison dropping into the joint. So those people who used to do some evils, so they thought that it is an evil disease. So a poison from the heaven or the hell dropping into the joint, causing terrible pain. So unwalkable disease. The disease of the kings, so who eat rich food with non-vegetarian, alcoholism, etc. It has a higher concentration of the protein. So this could cause major problems of a person afflicted with the gout. So gout is no more a arthritis, but is a systemic disease. No more a monoarthritis. Sometimes it may be the polyarthritis also. So France, for alcohol, for high non-vegetarian diet, milk, etc. A royal pain, gout, a royal pain. So this is another king of the pain, is the gouty pain. So there are a lot of the very famous fellows who were afflicted with your gout and gouty arthritis. Benjamin Franklin, Thomas Jefferson, Newton, Darwin, King Henry VIII and other famous leaders are all suffered from the gout. So incidents from the US, if you see here, they have given the 4 diseases: backache, osteoarthritis, gouty arthritis and rheumatoid arthritis. So this is number 3 in US, more than your rheumatoid arthritis. Next to the osteoarthritis. Suppose if you take back the low backache, so next to the osteoarthritis, this is a gouty arthritis so common in the Western population. What are the predisposing factors? Purine-rich foods, the meat, kidney, liver, seafood, oatmeals, certain vegetables like peas, beans, lentils, mushrooms, cauliflower, spinach, sweet breads. So they are all the foods rich with the purine. So once they are rich with the purine diets, so definitely there is a high tendency of to cause a gouty arthritis or to cause your monosodium urate crystals. So excess consumption of the coffee and drugs are very important. These drugs we often use day in and day out. Loop diuretics in all edematous conditions, in nephrotics, in heart failures, NSAIDs, steroids, niacin. Nowadays we are not using the niacin as a anti-lipid lowering drug, but earlier they used to write a lot of the niacin, but because of the because of the gastrointestinal side effects, we are not using the niacin right now. Cyclosporin, yes, post transplantation. Ethambutol, so very good in COX, pyrazinamide. Okay, so the ethambutol and pyrazinamide is one of the four important drugs to be used in all the COX people, along with your INH and the and rifampicin. So trauma in the joints in those people who are more prone to get the gouty arthritis, so that may be the precipitating factor. Some infections, some bacterial infections, some viral infections, some fungal infections may precipitate those people who are susceptible to get the gouty arthritis. And of course, your diabetes, so common, hypertension, very, very common in Indian population. Vascular diseases, again very common. Renal diseases, your CKD, so common. Thyroid is very common. Sarcoidosis is not that common, but all others are very, very common in our Indian population. So, as a physician, you should know everything about the gouty arthritis because it is very common in diabetes, hypertension, vascular disease like your CHA, IHD, PVD, and also your CKD, and also your thyroid diseases. So out of the 140 crores of the Indian population, if you had all these people, and definitely 100 to 110 crores of the individuals will have these diseases in Indian population. So gout is very, very common. As a physician, you should not miss to diagnose the gout, or you should give very good treatment or good ideal drugs to control the pain as the initial steps, and further not to have the recurrence also. It is our duty. So this is a very important slide. Take out some fluid there from your penna, your toffee, etc. and then check under the electron microscope. You will have these crystals. The group of the conditions which may be characterized by an elevation of the serum uric acid. So within the brackets usually. So it's not definite, not 100%. So don't expect 100% of the gouty arthritis individuals will have hyperuricemia. Okay. Even with the normal uric acid levels also, some people they may develop the gouty arthritis. Recurrent attacks, flares of an acute inflammatory arthritis with monosodium urate crystals demonstrated in the synovial fluid leukocytes. Bone and joint destruction in some cases. That is a very important thing. So you are not bothered about the soft tissues, or you are not bothered about your ears, etc. But we are much worried about the joints, bones, and the joints. See here the crystals. Okay, see the toffee. So aggregates of the uric acid crystals, the toffee in and around the joints, soft tissues, and also in the various organs. These toffee in the bone leading to the erosions in some cases, kidney diseases and the stone. So far you may get the 4 diseases with your hyperuric acids. So one, you may develop the gouty arthritis, you may develop the toffee, you may develop the nephrolithiasis, uric acid stones, or sometimes you may develop the nephropathy also. So that is gouty nephropathy. So gouty nephropathy or renal caliculi or toffee or gouty arthritis. So these 4 are associated with your elevated uric acid levels. So hyperuricemia is a biologically significant hyperuricemia, means more than 6.8. But some people even with the 10, 11, 12 also they may not have any symptoms. On the other hand, even with the uric acid levels of 5 and the 6, so they may develop the arthritis. So it is not directly proportional. The value, uric acid level value is not directly proportional to your disease. So less than the laboratory defined hyperuricemia. So laboratory defined hyperuricemia is more than the 9, whereas biologically significant hyperuricemia more than 6.8. See the dietary purines. So they form the urate, the tissue nucleic acids or endogenous purine synthesis. So this urate will cause hyperuricemia because of the under excretion when there is an overproduction or under excretion. So there will be the accumulation of your uric acid in the body. So this will cause a silent tissue deposition, a gouty arthritis, renal manifestations like nephropathy or the renal calculi, and associated cardiovascular events and the mortality. This is a very important take-home point. So as a postgraduates, as a physician, hyperuricemia is no more a marker for your gouty arthritis, but also a marker for your vascular diseases. So the people with more and more uric acid levels, so in one hand we are worrying much about the gouty arthritis. On the other hand, you should think of the early onset of your ischemic heart disease, vascular events. So the hyperuricemia is now a marker of your vasculopathy, like your microalbuminuria. So microalbuminuria is a marker for your nephropathy. Okay, but now it is also a marker for vasculopathy. The people with microalbuminuria, they will have higher tendency to get the ischemic heart disease and events and cardiac events. So this is the overproduction and under excretion. So while using the drugs, we have to use either the production has to be reduced or excretion has to be increased to reduce the levels of your uric acid levels. So hyperuricemia leads to the deposition of the urates in the joint fluids, triggering an inflammatory disease or cascade. See the chemotaxics attracts the leukocytes. There will be the inflammation, phagocytosis, rupture of the leukocytes, release of the cytokines. These are all the inflammatory cascades, markers, and then the deposition of these urate in the joint capsules and uric acid crystals will form. The same thing will happen in the kidneys also. So they will develop the uric acid stones there, and then finally they may damage the kidney to cause the gouty nephropathy or uric acid nephropathies. See, they damage the blood vessels, so they cause vasculopathy. They damage the joints, they cause the arthropathy, and they may also damage the kidneys to cause the nephropathy. So hyperuricemia means the three organs are very important, not only the joints in rheumatology, but also it has plays a major role in cardiology and also the nephrology. So the kidneys will be involved, heart and the vessels will be involved. So it's a purely a physician's disease. What are the stages? This disorder can be progressive through the 4 stages of the undertreated. Asymptomatic hyperuricemia. As I told you, some people, so when you are thinking that a young individual, a hypertensive and a diabetic, you are ruling out all the cardiovascular risk factors, and then you advise the uric acid levels, and uric acid levels are elevated there, maybe 9 and maybe at the 10 level. So this is asymptomatic hyperuricemia. Some people, they may develop the acute gout, king of all pains, terrible pain, very, very excruciating pain. That is acute gout. Then intercritical gout. So between the attacks, this phase is called intercritical. And some people, they develop the chronicity with the tophi. So there is a chronic tophaceous gout. So this is something concerned with your rheumatology. So all the 4 is in rheumatological manifestations, maybe asymptomatic, maybe acute gout, maybe intercritical gout, or maybe chronic gout. See the acute gout. See both the feet. So appreciate the involvement of the metatarsophalangeal joint there. Your erythema, effusion. It's a painful condition. Typically affects only one or a few joints. Mostly it's a monoarthritis, about 80%. Sometimes it may be the oligoarthritis, maybe 2 to 4 joints will be involved. And sometimes it could be a polyarthritis also. The big toe, knee or ankles are most often affected. throbbing, crushing, or excruciating pain. Joint appears warm and red. Fever may be there. So these are the common signs of the acute flares. Most common is the first metatarsophalangeal joint, affected 90% of the individuals with the gout. So then the ankle, the subtalar, maybe the midfoot. So these are all the four sides in your feet. Knee may be involved. In the hands, fingers may be involved. Wrist may be involved. Elbow, olecranon, and versa. So not the typical joints are involved. Very rare is shoulder and spine, the axial skeleton. Okay. See the fingers and the wrist. The same thing here. Okay, in the hands. It's the polyarthritis. Okay, multiple joints are involved here. So the attack may go away in a few days, but may return from time to time. Typically, it occurs at the night time, maybe 11 p.m., maybe 12 p.m., maybe at 1 a.m., and a very excruciating pain, and relieved by 4 a.m. or the 5 a.m. Again, the attacks will come on and off. Additional attacks often last longer. So first attack may last for about 20 minutes or 30 minutes or 1 hour. Second attack may be a little longer, and third attack may be much longer, etc. So the additional attacks often last the longer. After the first gouty attack, half of the people will have no symptoms, like your first convulsion. So earlier, even the first convulsion also you used to treat with the anticonvulsive therapy. Now, first convulsion you need not treat. Okay, so wait and watch and see the risk factors and see the raised intracranial tension is there or not, or any tuberculosis or neurocystic sarcosis, etc. So then only you have to give the typical treatment. Otherwise, wait and watch policy. The same thing happens here also. The first attack of the gout usually will have no symptoms. Half of the patients have another attack. Intervals between the first and the second flares. Majority experience second acute flare within 1 year of the first gout flare. Most of the people they have forgotten. So in 2014, maybe in the month of February or the March, I had a similar pain. But now after 1 year or 1.5 year or 2 years, they come for the second attack. So most of the people within 1 year, 62% of the population, and some may be the 2 to 3 years, some may be the 3 to 5 years, after 10 years, no second in more than the 10 years. So that is the incidence of the subsequent attacks following the first attack in the gouty arthritis. The take home point here is even after the 10 years also it may happen, the second attack. So no attack for the last 10 years. So most of the people they have an attack, second attack within 1 year, 62%. So this is a chronic gout. Signs and the symptoms include joint damage, loss of motion in the joints, joint pain and other symptoms most of the time throughout the day, tophi below the skin, around the joints or in other places. Tophi usually develop only after a patient has had the disease for many years. So not within the 1 year or not within the 1 year, 2 years or 3 years. It takes a lot of the years to develop the tophi. So by the time you see the tophi, and if you diagnose this could be a chronic gouty, so there must be a period of about the 5 years or 6 years or more than the 10 years to develop a chronic gout. This is the advanced tophi can be seen clinically with obvious deformity demonstrated in the hands and the foot. So very little can be done. These fingers and that these the hands because they're deformed. So there's a chronicity. The lot of the tophi is there, and see the X-ray. Maybe also the bone destruction as seen on the X-ray. No bone at all. Lysis, bone lysis. So this is also happens, and then there will be the fractures. A massive deposition of your monosodium urate crystals, so MSU crystals in the articulate, in the articular cartilage, subchondral bone, synovial membrane, in the capsule, in the sheaths, tendon sheaths, and the periarticular tissue. So these are all the areas where you can expect the tophi, not only in the joints, but also in the cartilaginous fascias. and also in the tendon sheaths, in the joint capsules, in the synovial membranes, etc. This formation can also occur over the eyelids, nasal cartilage, the cornea, the tongue, vocal cords, and also in the genital organs. So these are the different areas where the tophi formation can also occur. These nodules consist of the multicentric deposition of the ureate crystals and intracellular matrix and the foreign body granulation reaction. As they enlarge in the size, as they calcify, so they can cause the pressure symptoms. Because they are very heavy, they carry some weight and they cause the pressure symptoms. The tophi are foam, yellow in color, and occasionally discharge a chalky material. So most of the time it discharges the chalky material. So on inspection itself you can diagnose it is a tophi, it is a monosodium urate crystals, it is a chronic gouty arthritis. So this is the criteria. We always depend on the ACR, the American College of Rheumatology criteria. 77. The presence of the characteristic urate crystals in the joint fluid or the tophi proved to be contained urate crystals by the chemical means or the polarized light microscopy. The presence of 6 of the following 12 clinical, laboratory and the radiographic phenomena. So I am giving you the 12 criteria. 6 out of these 12 you can consider the patient is definitely a case of gout. More than one attack of the acute arthritis, that is history itself. You ask how many attacks he has. He said 2, 3 or 4, that is one criteria. Maximum inflammation developed within the 1 day. So the pain starts and the heaviness of the pain or the maximum intensity of the pain within the 1 day and the joint has become the swollen. There is erythema, there is a poor movement of that joint, etc. A monoarthritis attack, you give another point. Redness observed over the joints, another point. So these are all the only history on your clinical examination. First metatarsophalangeal joint is painful and the swollen. Unilateral, this disease is mostly the unilateral. Unilateral tarsal joint attack, tophi, either proven or the suspected. Hyperuricemia, your uric acid levels more than 9 or more than 8.5. Asymmetric swelling within a joint on X-ray or the examination. Subcortical cysts without erosions on the X-ray. Joint fluid culture negative for the organisms during the attack. That means negative for your bacteria. So you are ruling out the septic arthritis here because in acute onset, within the days, within the hours, etc., and the joint is swollen, erythematous, you suspect some sepsis there. So then send the culture, that is the negative. See, all these points are only history, and a few points on the clinical examination. So I am again repeating a one attack, more than one attack, maximum inflammation within 1 day, monoarthritis, redness, first metatarsophalangeal joint, unilateral, tarsal joint attacks, presence of the tophi, either the proven or the suspected, your elevated uric acid levels, X-ray shows asymmetric swelling, subcortical cysts on X-ray, and culture is negative for your bacteria. So out of these 12, 6 are positive. You are dealing a case of gouty arthritis. So you don't require any high-tech investigation. Even in X-ray is not needed to diagnose your gouty arthritis. Plain X-rays may be normal in most of the cases. You don't require an MRI or the CT. Serum uric acid is very, very important. Synovial fluid analysis shows the uric acid, that is also very important. And urea and the nitrogen, creatinine, so you have to respect our kidneys because these are urate nephropathy or uric acid calculi. So common, so you have to respect the kidneys and the heart here, vessels. Synovial biopsy when you are the doubt, and uric acid in the urine also, uricoguric effects, etc. So this is the synovial fluid analysis. Use the polarized light microscopy. It is a gold standard. Crystals are intracellular during the attacks, needle and the rod shape, and a strong negative birefringent. So this is the laboratory investigations. Uric acid, normal blood serum levels 9.6. Gouty patient, see the Gouty patient levels, even the 6. So 6 mm, 6 mg, at 6 mg also you can have a Gouty arthritis. Need not be more than the 9 or 10 or the 11. Don't treat the reports, treat the individual suffering with arthritis or tophi. Uric acid in the urine also you can detect, and urea levels and creatinine levels. In the BD, it's a very common disease, your pseudo gout. Here it is not monosodium urate crystals. And then the psoriatic arthritis, OA, RA, septic arthritis, cellulitis. So there is a common differential diagnosis for your gouty arthritis. See the psoriatic arthritis, which joints involved there? Distal interphalangeal joints, nail changes, skin changes, bilateral, extensive, etc. In osteoarthritis, mostly the large joints, maybe the knee joint involvement, maybe the ankle joint involvement, knee of then the hip joint involvement, cervical spine, lumbar spine, etc. Rheumatoid arthritis, again the hands, metacarpophalangeal, proximal interphalangeal, so not the distal here. Even though you have the nodules, rheumatoid nodules, they don't contain any monosodium urate crystals. They are not the tophi. Okay, so that's how we differentiate this gouty arthritis from the rheumatoid arthritis. Septic arthritis, again your culture and sensitivity will clinch, and cellulitis. So the gout versus the CPPD, the similar acute attacks. So the different crystals under microscope. So this is the RA. Both have the polyarticular symmetric arthritis. Tophi can be mistaken for RA nodules. But if you take a clear-cut history, so you can diagnose it. In rheumatoid arthritis, when will be the pain more? In the morning stiffness, early hours. They don't get any fever in rheumatoid arthritis. So they have the morning stiffness, hand involvement, etc. Whereas in gout, mostly the nocturnal pains, very severe nocturnal pains. Okay, and then the metatarsophalangeal joint. It's not usually bilateral; it's a unilateral. So that's how we can differentiate these things. So the treatment, NSAIDs are very important. You have to respect the NSAID. At the same time, you should know everything about the side effects of the NSAIDs. Okay, acute tubular necrosis. You have to respect the kidneys, and then the gut, gastropathy, NSAID gastropathy. Okay, edema of the body. These are very important side effects of your NSAIDs. Colchicine is a very useful drug in gouty arthritis. Uricogenic drugs, allopurinol, and now we are using the febuxostat also, febuxostat, okay, to reduce our hyperuricemia. NSAIDs, when the patient is very symptomatic with a lot of the pain, acute pain, so that inhibits the pain and the inflammation, inhibits the urate crystal phagocytosis by decreasing the migration of the granulocytes into the inflammatory areas. Indomethacin, naproxen, ketorolac. So here we use very high potent NSAIDs. So indomethacin works better. They are available in 75 mg, 50 mg. So you can use 1 BD or 1 TAD. So naproxen maybe 250 mg and the 500 mg, and ketorolac. So maybe the tablet form or the injectable forms are also available. Colchicine produces an anti-inflammatory effects by binding to the intracellular protein tubulin, preventing its polymerization, leading to the inhibition of the leukocyte migration to the affected area. Inhibits the synthesis and the release of the leukotrienes. So that is how the colchicine helps the patient in gouty arthritis, because it produces its anti-inflammatory effects and also inhibits the synthesis and release of the leukotrienes. See here the information, the same slide I showed you. Okay. Probenecid and sulfenpyrazone, these two are the uricogenic agents. They are very weak organic acids. Sulfenpyrazone is a metabolite of the phenylbutazone. There is another NSAID. Increases the excretion of the uric acid. So that's how it reduces the uric acid levels by increasing the excretion. Allopurinol inhibits the synthesis of the uric acid by inhibiting the xanthine oxidase enzyme. So this enzyme is responsible for the synthesis of the uric acid, for the formation of the uric acid. So by inhibiting this enzyme, xanthine oxidase enzyme, so there will be the no synthesis of the uric acid level. So obviously the uric acid production will be reduced. So that's how these allopurinol and febuxostat will work in these individuals. So uric acid is produced by the xanthine and hypoxanthine by the xanthine oxidase inhibitor. Uric acid is more toxic than either xanthine or the hypoxanthine. See the purine metabolism. First they cause hypoxanthine, then it converted to the xanthine. From the xanthine you will develop the uric acid levels. So in the presence of your xanthine oxidase, urinary excretion, that is allantoin or urate oxidase. So these are the important treatment goals in any arthritis in general and in gouty arthritis in particular, rapid and the acute flares, because the terrible pain, king of all pains. So reduce the acute flares, protect against the future flares. That is very important as a good physician. So you should protect from the future plans also. Reduce the chance of crystal induced inflammation. So these cause vessels may damage, the kidney may damage, the heart may damage. So reduce the chance of crystal induced inflammation. Prevent the disease progression by using your uricogenic drugs or inhibiting your uric acid synthesis by allopurinol and febuxostat. Correct the metabolic cause, provided the patient is obese or metabolic syndrome. So definitely you have to correct the metabolic cause by reducing the diet, by improving the physical activity, and if the patient is a diabetic, anti-diabetic medication, antihypertensive medication, etc. So ending the acute flares, the control the inflammation and pain to resolve the flare. It is not a cure. Crystals remains in the joints. Don't try to lower the serum urate during a flare. So when the patient is in the flare, don't give more importance to your NSAID therapy or your colchicine therapy or your etc. But not much use by using the allopurinol or your febuxostat in the acute flare. So they may have a role in the intracritical gout and the chronic gout, but not in the acute gout. So what is the treatment for your acute gout? The attacks, the NSAIDs, steroids, intraarticular, if one joint or systemic, if the multiple. This gives a wonderful results. So because it's a monoarthritis or mostly a oligoarthritis, so you can give the steroid injections in that particular joint, maybe one or two joints, and the people may get a tremendous response. Colchicine adjusts the dose in the patients with the renal insufficiency. So you have to respect the creatinine levels. Accordingly, you have to adjust the dose of your colchicine. Indomethacin as a NSAID choice, or you can use the naproxen or the Sulindac, that is a ketorolac. And steroids, 20 to 30 milligrams of prednisolone per day if the systemically used. And colchicine most beneficial in the first 12 to 36 hours of an attack. 1 mg initially, then the 0.5 mg until either symptoms relieved or the gastrointestinal side effects occurs. Total dose is about 7 milligrams during the acute flare. First start with the 1 mg and then slowly uptitrate the dose. And you have to respect the renal functions. When the creatinine level is more, so reduce the dose by 50% or 25% according to your GFR. When the creatinine clearance is less than the 10, so it's almost a contract. So stage 4. So fellows is on renal replacement therapy. So better not to use colchicine. So what about the protection against the future flares? So in acute flare you can control with your local steroid injection or with your NSAIDs or with your colchicine. Okay, these 3 drugs you are using to reduce your acute attack. But this is the most important. Protection against the future flares. So continue the long-term dose of your colchicine, 0.5 mg to 1 mg per day. Maybe the low dose NSAIDs, still the patient is having the pain. Both decrease the frequency and the severity of the flares, both your colchicine and the low dose NSAIDs. Prevent the flares, the start of urate lowering drugs. So this is the very important and best with the 6 months of the concomitant treatment. So this is intracritical gout. Education is very important. So not to take alcoholism, not to take the high diets rich with the purine. So lifestyle modification, diet modification, pharmacotherapy modifications, allopurinol therapy is always helpful for to reduce the future flares in the intracritical gout. So recurrent attacks despite the diet changes, etc. So under treatment of the nephrolithiasis, the serum creatinine is more than the 2, serum uric acid is more than the 11, 24-hour uric acid, urine uric acid is more than 800 milligrams, tophi are present. So use the allopurinol. Probenecid, if the recurrent attacks on 24-hour uric acid is less than the 800. Okay. So 24-hour urine uric acid is more than 800, use the allopurinol. If it is less than the 800, use the probenecid. So when the fellow is having the allopurinol toxicity, then you can change over to the colchicine. So again, this is in a physician point of view very important to prevent the disease progression. So lower the uric acid levels to less than 6. So keep it somewhere at 4, 5 or less than the 6. Depletes the total body urate pool, deposited crystals. Treatment is usually lifelong and continuous. So most of these rheumatological conditions, the treatment is usually lifelong and it is a continuous process. Maybe the small dose of these drugs. So to prevent the progression, a long course, so you have better to use the uricogenic agents or xanthine oxidase inhibitors. What about the asymptomatic hyperuricemia? Uric acid levels are higher, but the patient is asymptomatic. So what are the indications for the treatment? Like your subclinical hypothyroidism. So indications to treat the subclinical hypothyroidism. Okay, pregnancy or goiter. Okay, or your antibodies positivity. Okay, or symptomatic. Okay, so that is the way asymptomatic hyperuricemia. So when to treat? 24-hour urinary uric acid excretion more than the 1100. So treat it. Men more than 13, women more than the 10 serum uric acid levels. Even though they are asymptomatic, you can treat. So without symptoms, you need not treat from 8 to 13 in the male and 8 to 10 in the females. When it is more than the 13 and more than the 10 in the females, you can treat it. But hyperuricemia means more than the 8. More than the 8. So nephrolithiasis. So definitely, because these are all uric acid, production is more and is going to the kidneys and depositing there and causing the stones. Symptomatic, especially worsening of the renal function. Presence of gouty tophi in the bones or the soft tissues. So presence of the tophi, you treat it. Again, the presence of the goiter, you have to treat it subclinical hypothyroidism. Okay. Radiographic signs of the gouty arthritis. Impending a chemotherapy or radiotherapy for the leukemia or the lymphoma. So the lymphoma and leukemia people, the uric acid levels are very, very high. So if you start the chemotherapy, so there will be a lysis syndrome. Okay, so that to avoid that, so better to treat this hyperuricemia also. So these are the very important. So which drug to use? Best choice and the above considerations and whether the patient is an overproducer or under excretor. So these two are the cases for your hyperuricemia, either overproduction or under excretion. Need to get a 24-hour urine for the urate excretion. To know it, less than the 700 is an under excretor. So uricogenic drugs use. More than the 700 is a overproducer. Use allopurinol. So simple. So in the gouty arthritis, so not only serum uric acid levels, urine uric acid is also very important to differentiate between under excretor and overproducer. So urine uric acid level less than 700 is under excretor and more than 700 is overproducer. But 90% of these patients are under excretors. So the prevention, maintain the concentration of the uric acid level within the normal range, maybe 3 to 6. Drink plenty of water. So if they take plenty of alcohol, precipitate gout. Balance your weight with the proper diet and exercise. Avoid purine-rich foods. Reducing the alcohol consumption. Avoid the diuretic drugs. Okay. So this is the cherries. Foods known to decrease the occurrence of the gout include the dairy, foods high in the potassium, black cherry juice, blueberries, and the lemon juice. So these are all the treatments they have given the Hippocrates. Okay, BC, but still holds good even today. Okay, so cherries are immediately treating the gout will not allow it worse. Foods that prevent the gout. So the lemons, peppers, cherries. I think Guntur people won't get the attacks. They take a lot of pepper, cherries, turmeric, ginger, pineapple. Very good foods to avoid gouty arthritis. Okay. Newer drugs, uricase enzymes, the catabolize the urate to the allantoin, more soluble, extractable form, currently approved for the hyperuricemia in the tumor lysis syndrome. Some concern the fatal immunogenicity and unknown long-term effects. So thank you very much for your patient hearing.